Neurologic localization gets much easier when you match the exam finding to the structure behind it. In the next few minutes, we'll walk through high-yield lesion patterns that help you map symptoms back to anatomy. Start with the frontal lobe. Lesions here can make a patient disinhibited and impair concentration, orientation, and judgment. For eye movements, a destructive frontal eye field lesion drives the eyes toward the lesion, while a paramedian pontine reticular formation lesion drives gaze away from the lesion. Now add the medial longitudinal fasciculus. Damage here causes internuclear ophthalmoplegia, where the affected eye cannot adduct, and the abducting eye shows nystagmus. In a younger adult, think multiple sclerosis. In the dominant parietal cortex, the classic board-style pattern is Gerstmann syndrome. Think agraphia, acalculia, finger agnosia, and left-right disorientation. In the non-dominant parietal lobe, the signature deficit is hemispatial neglect. For memory, localize new learning to the hippocampi. Bilateral hippocampal damage causes anterograde amnesia, meaning the patient cannot form new memories even if older memories are relatively preserved. Move deeper in the brain and think in patterns. Basal ganglia dysfunction produces movement disorders, while a lesion in the subthalamic nucleus causes contralateral hemiballismus with wild, flinging movements of the limbs. Bilateral mammillary body injury points to Wernicke-Korsakoff syndrome from thiamine deficiency. Bilateral amygdala damage gives Kluver-Bucy syndrome, classically linked to HSV-1 encephalitis, with hyperorality, hypersexuality, and disinhibited behavior. In the dorsal midbrain, think paranoid syndrome with impaired vertical gaze, often up gaze. If the reticular activating system is damaged, arousal fails and coma can result. In the cerebellar hemisphere, lesions cause ipsilateral limb ataxia, dysmetria, and intention tremor. The cerebellar vermis affects the trunk, so lesions there cause truncal ataxia. For posturing, decorticate posturing localizes above the red nucleus, while decerebrate posturing points at or below the red nucleus and usually signals more severe brainstem dysfunction. If you remember a few anchor patterns, localization becomes much faster. Gerstmann means dominant parietal, neglect means non-dominant parietal. Internuclear ophthalmoplegia means MLF, hemiballismus means subthalamic nucleus, and truncal ataxia means vermis.